Yeah, that was, I think I talked
Hello,
on
good afternoon,
erectile dysfunction at that time.
Prostate.
Was it prostate?
May I have your
Okay.
attention? Now today we have the distinguished privilege of hearing from one of the icons of healthcare in this country. The gentleman presenting to us today has been a doctor longer than I've been alive. In East and Central Africa, he is the leading authority in urology services. Please put your hands together as we welcome Dr. Said Samnake, consultant urologist. He would prefer the title Mr., which is actually more appropriate, but because our video is being transmitted to the
CME to be effected. I'm very happy to be here. I came to this institution just to see how it was doing about 3 or 4 weeks ago, and I was quite amazed at the kind of work that is going on, and more importantly, the ethos, the what Jalaram is all about. And I was quite impressed with the extension of modern medicine to the less privileged of our population, and in a more affordable way. So thank you for that. And thank you, Victor, for that introduction. I appreciate it. Okay, so before I start, I must warn you, it's the evolution of management of prostate cancer, the treatment, but it involves a history which dates back to 4,500 years BC. So you will be challenged, you will be bombarded with lots of dates, lots of things happening in lots of various areas of surgery and urology. But just listen and get amazed by it, because later on, at the end of my talk, I will collate the whole situation to you as to how we should manage a patient with prostate cancer in this current day and age. So here we go. So we start 4,500 BC, which is the earliest evidenced case of possible prostate cancer found in the bones of some king in Siberia. And I think you can appreciate it would be Siberia because it's the coldest place, and so things have been preserved there for a long time. And the macroscopic, what they saw on the bones, looked like a pathological fracture from a metastatic lesion, most likely from prostate cancer. And in 700 BC, the earliest biochemically proven carcinoma, that means now in the same area, biochemically proven means they then got that lesion, not in the same person, in a different set of excavations. They got bones and they tested them and they challenged them with PSA, and it came back as PSA positive. Okay, after carbon dating them and everything. So that is how far back prostate cancer can go. But then if we start from there, we'll have problems finishing the lecture in 30 minutes. So let's jump to what is happening between the 1960s and 2016. Just an overview that in the 60s, about 60% of men, particularly in Europe, where the documentation was very good, they died of, if they were diagnosed with prostate cancer, within 5 years, 60% had died. Okay? And by the 80s, this percent, so if we actually compare apples with apples, it means in the 1960s, 40% of men in Europe survived for 5 years. Correct? By the time it was 1980s, we now have the jump from 40% survival rate in 5 years to 70% survival rate. And by the time we come to 2016, especially in the Scandinavian countries, the survival rate for patients diagnosed with prostate cancer has jumped all the way to 93%. So this is nothing short of a success in any field that you can think about. And what we want to know is, how has this happened in such a short time, from 1960 to 2016? How has this gone on? And just to remind everybody that as our age keeps on increasing due to good health services, etc. That advancing age is the biggest risk for developing prostate cancer in the first place. Okay. So way back in the 1800s, there were doctors and surgeons, early surgeons, who were looking at this disease of prostate cancer. And it was not only in one particular place, but you had people like Belling in Germany, Tancher in France, and John Adams in England, describing various aspects of prostate disease. And somehow they also saw that sometimes the prostate was more fibrous than other times, etc. But they were all getting the idea that there's something going on in this prostate which is sort of similar and unique to patients of the older age. And we come to 1867, and Tim Billroth did the first partial prostatectomy in Vienna. And in 1904, Hugh Hampton did the first radical prostatectomy. So, I don't know if there are any I beg your pardon. If there are any urologists here, we talk about radical prostatectomies as something very recent, but you can imagine if it was done in 1904, the medical fraternity, the people were thinking about it. They knew there was this problem here, and the best way to treat it was to remove the cancer and remove the whole lesion. But you can imagine how difficult it must have been, because you have to have the right anesthesia, you have to have the right tubes to join, you have to have the right anastomosis, etc. But people were thinking about this at the beginning of the last century. So this is the part of the surgical side. We are now going to see what happened in the diagnostic and radiological side. In 1895, everybody I think is aware, if there's a radiologist here, that Wilhelm Röntgen discovered X-rays when he could see the bones on somebody's hand, X-ray going through. And about 10 years later, you got Mr. Minette. Mr. Minette, he actually treated prostate cancer with radium via a urinary catheter. Remember, by this time, people like Pierre and Marie Curie had found out and discovered radium, polonium, and that's where the radiation technology has slowly come in, way back in 1905. And in 1938, Gutmann and Gutmann discovered what we call prostatic specific acid phosphatase, PAP, in metastatic disease. The problem with prostate specific acid phosphatase, which was the earliest biomarker for prostate cancer, wasn't very useful, because if it was positive and if the acid phosphatase was high, it simply meant that the disease has already spread to the bones. It is metastatic already. You couldn't get it early. But people were thinking about this. And then you have the very big strides in the evolution of management of prostate cancer. These 40 years, from 1940 to 1980, and you will hear a whole host of names, I think, which a lot of you will be familiar with. Of course, Huggins and Hodges, they were the guys who discovered the link between and the association between testosterone and prostate cancer with their work on dogs and other animals. And they found that if you injected the dogs with testosterone, you increase the chances of not only getting the prostate cancer, but also in its progression. And by the converse, if you gave these dogs estrogens, it actually suppressed the growth and the progression of the disease. Okay, and they won where I've written Nobel, it is for a reason I've written that they won the Nobel Prize in medicine for that. In 1945, Terence Millen, of course, described the famous retropubic prostatectomy, which we all know about. And the good thing about this was that it was, the access to the lymph nodes was possible with this, and it continued all the way till 1983, when Patrick Walsh in the US described what we now do, what we call a nerve-sparing radical prostatectomy in various ways. Coming to radiotherapy, in the major strides, again in the 1940s to the 80s, I think we were all, by the time we had graduated from medical school, me, the radiotherapy that was used was cobalt. And we could see how harmful and devastating side effects it had for very specific reasons, which I can't go into. But then we developed the mega voltage area, where the linear accelerators came in, and these allow better penetration of X-rays through the skin into the deeper tissues of the body. And it gave rise to what we call the EBRT, which is the external beam radiotherapy. IMRT, which is there a radiologist here? It is intensity modulated radiotherapy. Was then perfected in Karolinska in Sweden, and then brachytherapy, which is insertion of iodine seeds into the prostate itself, was then perfected by Hans Holmes in Denmark. Again, we are still on the major strides in the 1940s to the 1980s. A big leap was when the deprivation of androgen, which is basically testosterone and dihydrotestosterone, was looked at further, 1970s and 71. Shelley discovered the structure of LHRH, which is a luteinizing hormone, releasing hormone from the hypothalamus. And although this hormone enhances the release of testosterone, if it is supplied on a constant basis, it actually suppresses testosterone. This was a paradox, but this was discovered later. And that is what Sandro recognized in 1997, that the testicular suppression given continuously actually initially increase testosterone, and with time would suppress it. And this is one of the most common drugs that is currently used as a first-line management in prostate cancer. In 1989, we discovered the androgen in fact, we didn't discover the androgen receptor, where the testosterone actually attaches itself to create its effect, was discovered way back in 68. But it was only in 89 that anti-androgens, the earliest one of which was cyproterone acid, which is a steroid type, was approved for use by the FDA. Carrying on the advances in 40s to 80s, and if you look at the diagnostics at that time, in 1966, the Gleason score was established. And this is a score which ranged from a Gleason 1+1, which is 2, to a Gleason 5+5, which is 10. The 1+1 being, and this is histologically, looking under the microscope, the tumor, which the 1+1 was the lowest, the most slow-growing part of the slowest growing aspect of the tumor. And the 5+5, a Gleason 10, the most rapidly growing and anaplastic tumor. So that score came into being, and it lasted for a long time, but you will see later on that that one was also remodified in the last 10 years. The discovery of isotopes, especially with the bone scan, which we need to do, which took a long time, from 71 to about 5-10 years ago, by Subramanian and McCarthy. And this was the mainstay in finding out whether there was distant metastasis, because the predilection for spread of prostate cancer is to the bone, by far. Again, following that, in the same year, CT scans came into being. You will remember the name Hounsfield very easily, because his units are used to describe the way the images project, and Cme, and again, they won the Nobel Prize for that. And in 1973, MRI imaging became popular in urological work, and it is one of the mainstays in diagnosis and treatment of prostate cancer. And again, Lauterbur received a Nobel Prize in medicine, in radiology for this. Then in 1979, we had something called the PSA, which you all know about, I'm sure. PSA stands for prostate-specific antigen. This is an enzyme which is produced by the prostate gland, which is used in helping the motility of the sperm in the prostate. And but more importantly, it was demonstrated that if there is an inflammation or overactivity of the prostate gland, then the PSA level goes up. So just to clarify that for you, that the prostate-specific antigen is specific for the prostate, but it is not specific for cancer. So it doesn't mean if the PSA is high, that is, it is definitely cancer. Yes, if the PSA goes to above 10, 15, then you can say it might be. But it is prostate-specific, but not cancer-specific. Okay, you need to remember that. And my friend John Cme in '87 in Stanford demonstrated the usefulness of this molecule in BPH and also in prostate cancer. And by 1989, we were then doing biopsies of the prostate under what we call TRUS guidance. TRUS stands for transrectal ultrasound, where you were targeting the prostate nicely, seeing the lesions, and then biopsying them. And in the beginning, we were doing 12 core biopsies just all over the place, because the prostate surrounds the urethra and has got several lobes, and we were just doing that at that time in '89. So what's happened between 1990 and now? What's happened in the last 30 years? One of the main advances that we have seen in management of this disease is the advent of chemotherapy. Before, there were no chemotherapeutic agents at all whatsoever that would touch prostate cancer. It was such a stubborn disease. And in 1996, the onset of mitoxantrone was introduced to treat mCRPC, which stands for metastatic castrate-resistant prostate cancer. In 2000, the androgen pathway, the androgen receptor, which I had earlier alluded to, which was discovered in '68, now became a more closely studied receptor. And we then developed in the 2000s the intracellular inhibiting agents like abiraterone, enzalutamide, and apalutamide. These are the anti-androgen, and darolutamide. In 2003, I talked to you about the LHRH antagonists, the goserelin and buserelin and luprolide before, but these are LHRH agonists, antagonists, which directly confront the LHRH secretion, like aberylix and degarylix and reguloids, which are there. In 2004, again, going along with chemotherapy, one of the most common used chemotherapeutic agents for prostate cancer now is docetaxel. And if it doesn't really work very well, and for very specified patients, you can use cabazitaxel, especially for metastatic hormone-sensitive prostate cancer and metastatic castrate-resistant prostate cancer. Going on the same period of time, something called the PSMA and the nuclear medicine era saw a huge surge in how we managed this disease. 1987, if you can pronounce that name, you're fine. He identified a novel antigen, which was called PSMA, stands for prostate specific membrane antigen. It is an antigen, a molecule, which is only at the site of the cancer cell on the outside. And in 2012, we started getting the imaging techniques and therapy that increased in metastatic castrate-resistant prostate cancer using PSMA and PET CTs. And in 2021, which is only 3 years ago, there is something called theranostics, which is PSMA, which is labeled with a component radionuclide. So the PSMA gets stuck when you inject it to the site of the prostate cancer, and the lutetium, which is the radioactive molecule, kills that cell right there. Okay? So theranostics, you diagnose it, and it's also therapeutic at the same time. Okay, and this is the cutting edge of modern treatment of prostate cancer. The other advances in the last 30 years that we have made is in what we call precision medicine and immuno-oncology. So you have genomic and genetic testing, especially we are seeing patients younger in age with prostate cancer. You have seen that, and I'm sure you know that that families in whom you have seen men with prostate cancer, their uncles or their sons or their children also tend to have prostate cancer. And so we are trying to identify the genes that propagate this disease. Okay? We are now looking at poly-ADP ribose polymerase, what we call PARP inhibitors. One of them is called olaparib. And this particular one actually targets the gene itself, like the BRCA1 and BRCA2 and ATM. And what PARP does is if I can explain a bit, it rejuvenates or repairs genes that are going bad. But if you have a PARP inhibitor, the inhibitor prevents this reparation to take place and therefore causes cell death. If you repair it, you will survive. If you prevent the repair of that cell, the cell will die. I hope you get that point. Okay? Immuno-oncology, this has been limited, but we have Sipuleucel T and the other drugs that we use for this targeted therapy. And for more targeted therapy, we actually target single enzymes like P15, P4Ka to stop causing a mutation in the gene. So you can see how much advancement is made in various sectors of medicine to eventually focus on prostate cancer. We are getting to the end, but it is a long journey. So the changes in diagnostics has greatly affected the way we treat prostate cancer now. And I mentioned to you the Gleason score earlier, which was 1+1, the lowest form, and 5+5, which was the highest grade. So in 2005, the International Society of Urological Pathology, they recategorized this whole thing because they found out that by using this system, we were actually over-treating patients with prostate cancer. Because they realized that patients who had a grade group between 1 and 3+3, which is 6, a lot of them didn't need much treatment because the natural history of prostate cancer is that it is a slow-growing disease, and if you get it at the age of 75 or 80, you're more likely to die with the disease than from it. Okay? So we were over-treating the prostate cancer. So they came up with a different score, modified the Gleason score, and put them into 5 groups, which are here. So they left the 1+1, 2+2, 2+3, 3+, and they came to 3+3, which was regarded as a low-risk group, and a 3+4, intermediate but favorable risk, and 4+3, intermediate, unfavorable risk. 4+4 was categorized as a high risk, and if you had a score of 9 and 10 was a very high risk. Let me explain, if I can, a little bit. The 1+1 and the 3+3 and 4, this is what you see under the microscope. The first figure you see of the 3+3, for instance, is the worst the worst picture that you can see under that microscope. The largest, worst picture you can see, and that is might be a 3. Then, of course, I can't go into the categorization of how to do that. And then the second 3 is for the second most common feature that you see under the microscope. I hope you get that. That's why the 3 plus 4, which is 7, is not the same as the 4 plus 3. Because the 4 plus 3, the category of 4 is worse than the category 3. Okay? So if you get a Gleason score of 7, you have to differentiate it between whether it is a 3 plus 4 or a 4 plus 3. Okay? Okay, and in 2010, we had this great thing that we did with the MRIs. Before 2010, the tendency was if the PSA is high and the prostate is enlarged, we would first go ahead and do a prostate biopsy. That was the first thing we did, so that we could get a histological diagnosis. Okay, and the biopsies we did were just putting our finger in, guiding the thing, the gun, and then doing it. Now, of course, I've told you